Okay, and then I'm going to start the webinar there. So welcome everybody who's joining us to the first webinar of the second season of Liaison Psychiatry webinars. We're just waiting for people to join and the participant count is going up. We've got 67 attendees so far. We'll just give a little more time for people to join us before we kick off with some introductions. So the account's still going up. We're just at 7 o'clock. So the first webinar in our autumn and winter season of webinars on the 17th of September. We've got a few more people joining, but we'll wait. It's probably going to hit about 100 attendees before we start, and we'll expect a few more people to join us over the first few minutes. Okay, so I'm going to start by introducing the organising committee. My name's Dr. Alex Thompson. I'm a consultant liaison psychiatrist at Northwick Park Hospital. I'm joined by Dr. Emma McAllister, who's the lived experience advisor for the college liaison psychiatry faculty. Dr. Shami Shetty, a foundation doctor here at Northwick Park Hospital, and Dr. Joel Richardson is not here tonight, but is helping us to organise, is another foundation doctor. So the format, we've got two speakers. I'm going to be talking for about 10 to 15 minutes each. You as audience members, unfortunately we can't see or hear from you directly, but we're really keen to hear from you in the chat and encourage you to interact. So first of all, if you can find the chat box and if you can select all panelists and attendees rather than just all panelists, then please do say your name, where you're connecting from, and say hi to everybody else. Secondly, we've got a Q&A box, and if you have a question that you want to put to the panelists, we will prioritize questions that are in the Q&A box, and you can click thumbs up and prioritize the good questions you're particularly keen to hear answered. So after our talks, we will have a Q&A session, and we will finish at 8 o'clock. There's no clap for the NHS anymore, I don't think, but we'll make sure that you all get away on time. Final thing to say is that we've had no problems with disruption so far, and we don't anticipate any problems. If we do run into any difficulties, we will simply end the webinar. So if you find that the thing ends abruptly before 8 o'clock, just click on the link and rejoin, and we will get started again. So now I'll move to introduce our speakers, two speakers today. Firstly, we're going to hear from Dr. Trudy Seneviratne, who is the Registrar of the Royal College of Psychiatrists and a consultant perinatal psychiatrist and clinical director in South London Maudsley NHS Foundation Trust. And secondly, we're going to hear from Professor Michael Sharp. He is the president of the Academy of Consultation-Liaison Psychiatry and a professor of psychological medicine and the trust lead for psychological medicine at Oxford, the University of Oxford and Oxford Hospitals Trust. So while you're introducing yourselves, I'd also encourage you to interact and to give some feedback to the speakers in the chat as well. We're going to hear a bit about the Royal College of Psychiatrists, a bit about changes to services in response to the coronavirus pandemic, and it would be really helpful to hear a bit about what you see as the priorities for the college over the coming years. A really big topic which we've touched on a lot in the previous webinars this year is the mental health emergency centres, emergency departments, clinical decision units, and we don't really, I think, have any consensus about what the ideal, good practice or gold standard is for emergency centres or emergency provisions. So if you can sort of comment from your experience about what you think the ideal offer should be, what you think the college needs to support you with as well, and perhaps some feedback about how the Royal College of Psychiatrists and the Royal College of Physicians could most usefully work together in the coming months and years. Then feedback about the Academy of Consultation-Liaison Psychiatrists. What can we learn here in the UK from the USA? And do we have any members of the ACLP? What are the benefits of membership, and what have you got out? And should we in the UK all be joining the ACLP as well? So get chatting, get talking, and I will hand over to our first speaker now, Dr. Trudy Sinevaratna. Go ahead.
Brilliant, Alex. Thank you so much. And thank you so much for inviting me to be part of one of your very, wonderful webinars. So I'm going to do a bit of a reflection, actually, of 3 parts of my world at the moment, which is, and I hope that'll be interesting I've seen some of the names. I've just been trying to clock the names as they've been joining. So hello to lots of people out there. Lovely to see you. So I thought it might be nice to, hopefully, a reflection of 3 aspects. So stepping into, I guess, a registrar role at the college, and also my clinical area, which is as a perinatal psychiatrist in SLAM in South London and Maudsley, and also a managerial area, which is as a clinical director there, where I have been, with colleagues trying to think really carefully about our crisis ED liaison pathways across all ages. So would really value sort of actually a rich sort of feedback to some of those questions I posted earlier, which Alex has really kindly already discussed. So let's start with the college bit, shall we? So, I mean, I know I'm exhausted this evening. I feel like I've had a really busy day, a really busy week. And I think, many of you will know our college values. And I'm so pleased that as a college, we came up with these fantastic college values a while ago. Because I think as psychiatrists and clinicians and, both, and also having to deal with our personal worlds and lives through COVID, we've had to embrace all of these areas, haven't we? And I did a quick brainstorm actually with some of the other college senior officers to think about actually what has the college done in the time that has happened. Well, what have we done? What's the college been doing? And do you know what? I got the longest list from our senior college officers of everything that's happened, and it was really exciting to read it. I can't possibly go through all of them, but and that's with your help and with the help of our members. So hence that question about what can the college do for you, because it's given the reach that we now can have in this virtual world. I really think that our reach can be even greater to our college membership, and as a body we can do even more together. So let's do it. So that's my sort of one big ask. So what have we done? So obviously we've rapidly became a virtual college. We have produced some fantastic material with, again, the help of you as experts for guidance for our patients, our service users, our carers for services, working alongside other organisations and colleges and bodies, working with the brilliant policy team and produced, you know, some very rapid publications, which have continued to churn. It has been, you know, really extraordinary and incredibly useful. And that output, I think, has been so valuable. And people did that work, you know. Thinking of Jim, your faculty chair from the liaison faculty, working, and he and I sharing stories, as I think COVID hit us sort of at a similar time. And of course, we were doing college work at the same time. And can we move on to the next slide? I think might be just so you can see some of our other colleagues hard at work. So, you know, there's been a real commitment to keep the training going, you know, through the entire career trajectory, and you know, really accelerating digital papers, paper A and B, that has been accelerated. People, I know trainees are currently sitting the digital cask, and Kate Lovett was at the college today. I think it might have been her first trip back to the college to help with an engine room that's been getting the cask going. And of course, that's so important that trainees have been able to continue on their career trajectory. You know, here we are doing this webinar, but all the virtual learning that we're able to do and has been delivered, and having a fill rate of, you know, 100% fill rate for the core trainees, it's extraordinary. The core trainee fill rate has been 100% through a pandemic. You know, I can't listen more, but you know, it's something like setting up a Section 12 course so that we as psychiatrists could continue being able to practice as psychiatrists and get our AC approvals has been critical. And other areas of the college, like the CCQI department, have done a fantastic job in keeping those services being reviewed and peer reviewed and accredited. You know, plan liaison accreditation, the perinatal accreditations that are happening. Really, really great work. And of course, you'll know Ian, our chief examiner, Ian Hall, and Kate, our dean. Next slide, please. And some really important surveys through COVID as well. I think that we've had, you know, we've taken some important messages. I'm hoping you'll all have read this report, which Ananta Dave chaired, bringing this group to really thinking about COVID-19 on our BAME population, and you know, very simple recommendations like ensuring that people have a good risk assessment and the right questions are asked. You know, these things sound simple, but go a very long way into supporting our well-being. I'm not going to go through all of them, but please do read it if you haven't read that. Next slide, please. So that's the college part. So I'm going to move into the perinatal world, and you know, as liaison psychiatrists, you very much feed into a very important pathway within perinatal psychiatry and perinatal services. And I've spotted a few perinatal psychiatrists on the call joining as well. So please ask questions there. Again, it's been, you know, incredibly challenging, whether it's, you know, the preconception pathway into the liaison pathway, our relatively newly expanded community services in the last couple of years, which is a brilliant global good news story, our expanded mother and baby units. But actually what we saw is, you know, like many services, there was a reduction of referrals into services at the start of the pandemic, but actually those referrals have hiked up gradually as time has gone. And perhaps because of the closure of primary care services, there's also been an influx of people with anxiety into our community services who probably wouldn't necessarily have come into those pathways. So again, it's a piece of work we're going to have to monitor. There's an enormous impact on women themselves. Yes, the additional anxiety that everybody is experiencing, but actually a whole range of additional presentations, you know, heightened PTSD, heightened OCD, heightened psychosis. So again, I guess as we look at the epidemiology as time goes on, it will be really important to look at this. other simple but important social factors like reduced contact with professionals and virtual contacts, or indeed things like having to give birth in isolation at the height of COVID. You know, that's had profound effects on people. And having had a baby and going home, you know, if there were partners and family members supporting, not for everybody, of course, but, you know, the reduction in the level of support, and that extended to not having usual visits from professionals, but also not accessing sort of mother and baby groups or childcare. So very, very challenging. And, you know, stepping onto a mother and baby unit where the bulk of my clinical work is currently, it's been interesting to observe, and we had to reduce the MBU down from a 13-bedded to a 10-bedded unit to facilitate COVID beds on the unit at the Bethlehem. But actually most of the admissions have been for very, very acute psychosis. So it's been a period where the dominant admission has been a range of psychotic disorders, whether it was mania, puerperal psychosis, or psychotic depression. And as one often finds, a number of delusions related to COVID, or being convinced that they've caused COVID, or other such delusions, and things like Capgras delusions have been also in some way tied to COVID. That's for, you know, that's for another time. And of course, women not wanting to come into hospital, even if they're very, very sick. And, you know, in the UK, we're so lucky we have 21 mother and baby units when people do get very sick. And additionally, restricted visiting when partners can't actually even come onto the unit. I mean, they can now in all of the units, but that was restricted for a long time. Even now, it's still restricted. And another really curious, I guess, moving into the research domain, is thinking about the longer term impact on the fetus and the baby in this period, and what the longer term impact may well be on that child if there is indeed a sort of, you know, increased anxiety or increased psychiatric conditions in the mother. So, you know, if one thinks back to the Spanish flu pandemic 100 years ago, and the potential impact on the children later, and some of the data we saw there of, you know, was that related to psychosis, for example, you know, time will tell, and it will be really interesting research to follow forwards. Thank you. Moving on. Next slide, please. And the other area, so this is a different hat, I guess, but this is where the liaison work really has been fascinating. And I guess, you know, I know as a group of liaison psychiatrists and a faculty, you will have thought very carefully about this. And I know there are many, many different models of setting up CDUs, crisis decision units, or alternatives to an ED presentation. And this was a piece of work that we really undertook as the pandemic hit, and working alongside a fantastic group of people and service users, clinicians and academics, and Bruce Clark, who is a child psychiatrist. Next slide, please. We wanted to look at a whole range of values, from clinical outcomes to service user carer, patient feedback, as well as, staff feedback, to thinking of cost issues, environmental issues. So an entire steep analysis of what had happened. Of course, these, so if we look in, you know, what happened across South London, we stepped up to effectively clinical decision units. One that were both of them not linked directly next to an ED department, but sort of one was across the road, one was sort of an entire borough away, another was sort of in the psychiatric department near an ED, but not quite. So it was really, so that was one. The other one was starting a CAMS crisis line across the SLP 12 boroughs across South London, and providing a sort of new 24-hour crisis line. And although the CDUs were supposed to be all age, what we saw was that in terms of our data and learning and narrative, was that actually many people, young people, adults didn't want to travel 2 boroughs in the height of COVID to a new unit. I mean, these are all things I know you will have thought about in other liaisons, webinars and discussions. But people didn't want to travel, and what what we normally see in terms of breaches in ED departments were long. So even in a CDU setting, those breaches were excessive, and people didn't like sitting waiting in an environment which actually wasn't completely suitable for a non-ED setting, and the delays were longer than expected. So fewer people use the CDUs than perhaps we thought we're going to use them. There were the geographical issues, and this is really important. And I know we talk about this, but the real issue of parity of esteem, and that actually acute trust partners, once we've set up these units, not really wanting to return to what was before, and being quite content that people with mental health problems were being diverted elsewhere. So the resistance in returning to something, and we have returned to something in one setting because actually what was set up we thought wasn't the right way forward. Nevertheless, the plan is to sort of set various alternatives up across the patch and the organisation, but it's not clear what's required, and I'd really love to hear from this group what you think the ideal setting should be. Next slide, please. And very quickly, I guess this is what we would have seen nationally, and I've seen data nationally as well. These slides just show you that there was a that significant drop from lockdown happening. I haven't got a pointer here, I don't know whether you can see that, but you can see the obvious drop in all ED presentations around that March-April time. And as time has moved forwards, those presentations are right back up there to pre-COVID levels. And whether the CDE is there or not, the ED departments are extremely busy. Next slide, please. And sorry, you don't need to go back, but also there were additional presentations to EDs with anxiety during that patch, probably because of reduced availability of primary care. And when we looked at the CDUs, this is just showing this was a mean of 10 people seen across a period through that code through April, May time this year, and so really not seeing as many people perhaps as we would have liked. Next slide, please. And that's really moving on to the end of my talk. I'd love to have some rich discussions around these questions, and just look at how the college perhaps can help further with certainly an all-age ED CDU pathway and all the other terms that we give for that particular clinical offer. I'd love to hear about what you think the college can do more to support you both individually, whether it's well-being, whether it's training, whether it's support with services, and the other piece of work that is newish is a conversation with the Royal College of Physicians, where we're thinking about how the two colleges particularly can combine to support some of the work in the acute trust within both liaison, but also the wider liaison setting. So again, what do you think that most useful piece of work might be? So thank you. I shall stop there.
Thanks very much. And it's just 7:25 now, so you're bang on time. We've got 152 attendees joined us. I'm delighted to see so many, and there's been some really, I think, rich chat as well around different models of the sort of mental health emergency centre, emergency department working, and I think perhaps we need to evaluate these a little bit more. And the RCP, I think there's a few comments on this. I wonder about the need for perhaps focus with the RCP not just on the acute and emergency pathways, but on the sort of community health and that side of so the other side of liaison psychiatry and the psychological medicine and the scheduled and the planned stuff. And I anticipate we're going to hear a little more about this from our next speaker, so I will hand over to Professor Michael Sharp.
Just Micah, can you hear me all right, Alex?
Yes, go ahead.
Great, good. You're the test case. So. Thank you very much for asking me to speak. I have 3 jobs. My proper job is I work in the University of Oxford and do research in Psychiatry and General Hospital, which is fun. The second job is I'm the trust lead for psychological medicine in the Oxford University Hospitals, which, as many of you know, is a fully integrated psychiatry and psychology service in the acute trust. And then this other random thing that I am doing, which is really exciting, and I've been asked to talk to you today about, is I've got involved with this American organization called the Academy of Consultation-Liaison Psychiatry. Now, I say I got involved. I've been involved with them about 25 years. And weirdly, I'm now the president of it. But, you know, luckily because of COVID, instead of having to go to the States all the time, I can just do Zoom calls. So we now do all our board meetings by Zoom. So it saved a lot of traveling, COVID. Okay, so I wanted to just tell you a little bit about the Academy. It's a really great and dynamic organization. I want to tell you what it does. I want to tell you how I got involved and something that might be of use to you. I want to mention a few initiatives in the world that we occupy from the States. And finally, I want to tell you about our annual meeting, which you don't have to go to America for anymore because it's going to be virtual, like these great webinars. So first of all, what is the Academy? Well, the first thing is it's American. It aspires, as you see, to an international mission, but most of its members are in the United States. And it began, if you know your history, there was a vogue for something called psychosomatic medicine in the 1950s. And this really came out of the enthusiasm for psychoanalysis and how psychoanalysis could maybe, or psychoanalytic factors could explain medical conditions and we could treat those with psychoanalysis. So it started off in the 1950s, by all accounts, frankly, a fairly wacky organization with some guys that smoked cigars, drank whiskey and met around a swimming pool, and sadly those days are gone. It's evolved since the 1950s, and in, I think it was 2003, a critical change happened and it became the official organization for liaison, and referred to in the USA as Consultation-Liaison Psychiatry in the United States, so for the training and for representation of CL psychiatrists. So this is very different from the college because this is a freestanding organization. The exams are done by a different statutory American body, but this is the organization. So nearly all, not all, CL psychiatrists in the USA are members of this organization. It was kind of strange being called, oops, sorry, you're ahead of me, Alex, can we just go back? It's kind of strange being called the Academy of Psychosomatic Medicine. And so in 2018, it changed its name to the Academy of Consultation-Liaison Psychiatry. There are about 2,000 members, and if you want to rummage around and find a bit about it, there's the web address, clpsychiatry.org. Now you can move, Alex. Okay. Oh, we got a bit, something's fractured a bit on the slides. We got a bit of the last slide and the new slide, I think. Okay, thank you. So I've truncated it a bit, but the Academy has a grand vision, really, to work towards everyone who's medically or physically ill who needs it should be able to get psychiatric care. I mean, obviously, we're a long way from that in the USA as we are in the UK, but that's the motivating vision. And the mission is to promote this agenda of excellence in the care of these patients with comorbid psychiatric and general medical conditions by advocacy, by research and by education. So there's a big educational mission. Now, the international bit, being American, and I apologize to John Levinson or any American colleagues on here, but you know, America does tend to be less now, a little bit insular. But we are reaching out, and there are other organizations like the EAPM is a strategic partner, and the liaison faculty of the college is a strategic partner, and that has a practical implication I'll come on to at the end. That doesn't mean you shouldn't join ACLP, of course. Next slide. Okay, we've got a bit of an interesting glitch again. There we go. So this is the vowel bit. So ACLP last year went through a strategy review. So the board, this is done the proper American way. We have external consultancy who interviews people, meets with the board, and tries to tell us what we think our strategic priorities are. And it was a pretty good exercise, actually. So as you can see, following from the vision and the mission, there's an important advocacy role. So there's a number of aspects to that. We have a voice in the APA, and now we're going to have a voice in the AMA, the American Medical Association. We support our members in making the case for CL services in their hospitals. So generally we are the go-to organization for arguing about the role of psychiatry in medical care. A big mission is the E, which is education. And the strength and the weakness of the Academy is that it is a psychiatrists organization. So we have physician members, we have some nurse members and others, but it is predominantly a CL psychiatrists organization. And one of the issues at the moment as to what extent we expand our educational activities, and for example, attendance at the meeting and other things, to people from other disciplines. That is happening a bit, and there's a bit of a question whether we should push to do this more. I think we probably should, and we probably will. An important bit comes under the heading Inspire, and this has been really important this year. So the Academy keeps very engaged with its members. We have listservs, we have special interest groups, I'll come on to that, for which have meetings like this. We have the annual meeting to get people together. We do a lot to try and keep up the energy, just like Alex is doing here, keeping up the energy, morale, and linking of our colleagues. And during COVID, which hit some bits of the US very hard, about New York particularly, we have set up a specific listserv and specific curated activity on the website, which you can have a look and see, and the kind of chat that we're having here for people, exactly as we heard before, for people to work out how to do stuff, because nobody knew how are you a sales psychiatrist in a hospital that's full of people with COVID. So we're moving down the vowels. O is to optimize, and I'll say a little bit about this. This is a freestanding organization, so it doesn't have the infrastructure of a Royal College, has its own budget, its own staff, and of course we have to make sure that we're being effective as we can, and we're using our funds effectively as we do. So we're slimming down some of our activities in that regard. So just to complete the vowels, the U, this global vision can only really work if we partner with other organizations that share the mission. So they don't have to be psychiatrists, they just have to share this view that they want to improve life for people with comorbid medical and psychiatric conditions. And there are quite a lot of organizations, if you rummage around, that actually do that. So that's a work in progress, but as I said, the RCPsych is an early partner there. Okay, next slide. So I say it's a freestanding organization. So there is a board, and that's a board of CL psychiatrists, and they run the organization, they make the strategic decisions, and each year we have a president of the board. There's a secretary and a treasurer and so on, and I shall be your kind of pre-president for 1 year, a president for a year, and then a past president for a year. The organization has lots of committees run by volunteers on different topics, education, finance, and it has a large number, it's over 20, I think now, SIG, special interest groups on things like transplant. See Steve Potts is here, he will know that. All sorts of things, virtually every topic in CL psychiatry you can imagine. Just to make you a little bit envious, it's a big organization to run, but it has a fairly large budget, and we have about $2 million in the bank. And we have a professional management support company. That's how things work over there. You may be familiar with the Academy by the journal, which is currently called Psychosomatics, edited by someone called Ted Stern at Boston. Starting in January, that's going to be renamed JACLP, the Journal of the Academy of Consultation-Liaison Psychiatry, and it's going to be edited by Ben Lee. Some of you, Ben Lee Ho Chang, some of you may know from Rochester. So that's hot news. Look out for that. Next, please. So how the hell did I get to be doing this? And it goes back a long time. So I think sometime in the 90s, when I was a trainee, one of my seniors then, Richard Mayer, who was called, said, you know, I've been to this America and the States, you know, you're interested in this liaison psychiatry. I think you should come here, you'll find it interesting. And the meeting was actually in Phoenix, I think. So I went out there, and of course it kind of blew my mind. And you just get to go up and talk to these people that I heard about. So that's Wayne Caton there, who it's a huge amount of research in liaison psychiatry, invented collaborative care. There's Jim Levinson, who edits the big textbook, did the biggest trial of liaison psychiatry that's ever been done, and a great hero, and many more. People like Cronky, who did the PHQ-9. So this was just amazing to have a chance to talk to these people. And people say, well, you know, what was it to learn from America? And actually, the stuff they do, you know, the money's a bit more transparent. The issues are basically the same. They grapple with just the same stuff that we do. But because it's a fragmented healthcare system they have there, that you could say that's a really terrible thing. But what it does, it means you get lots of local innovation. So the different systems can try out different models of delivering care without it having to be a monolithic NHS thing. And that means there's some great ideas come out of there. It's a very passionate, professional, and innovative group of people, and I've really enjoyed being part of it. So there we are. About, I don't know, 7 or 8 years ago, someone tapped me on the shoulder and said, Michael, you've been coming to these meetings a long time. And I said, yeah, they're great. And they said, Michael, we think you should serve. So that's how I was put on the board, and then I worked my way up, and then of course I found myself as president, which I had some trepidation about whether I could really do it in the American scene. But actually the issues are so common to what we're used to. It's gone very well, though it's been an interesting year, as we all know. Next slide. So just to mention a few things that go on there that are of interest to us. I mentioned collaborative care, which is how you provide psychiatric care for patients in general practice or outpatients. And there have been, I think, 100 clinical trials now finding that collaborative care is effective and cost effective. And that I learned all sorts of things from that. I learned about monitoring outcomes, treat to target, focused patient groups, the clinical trials of services. So that's a fantastic stream of research coming mainly out of Seattle and University of Washington. It's been terrific. The latest hot thing in CL in the States is something called proactive consultation. I don't know whether you've heard about this. Case came out of Yale originally, and it's the idea that rather than be reactive, like many of our services are, waiting for the referral, you go in there and you get stuck in and you look for business. And when you find someone with a problem, you follow through with their management in collaboration with the physician. You don't just give them an opinion and go. That's on non-randomized evidence has looked very effective and cost effective, and it's now been adopted in a lot of hospitals. We still need a randomized trial, but that's a very exciting innovation. And also, it's not unique to the States, but they've done some great pieces of work on integrating psychiatry and often funded it, as this example here in the picture. That's a guy called Dave Gitlin from Boston. And many of these places get a donation or some funds to fund a psychiatrist to work full-time in a service. And they in that service, they integrated the psychiatry into the intensive care unit. And again, by all accounts, was very successful. So there's lots of exciting stuff going on there and lots of stuff to learn. Next, please, Alex. So, oh, we fracture slide again. I have to bring some stronger slides next time. Okay, so it's still slightly fractured, but this is, I want to tell you briefly about, it's still fractured, Alex. I don't know why that is. Interesting. Can you not mend it? So, thank you. So I want to tell you about our annual meeting. Now, I think a few of you have been to these meetings. I mean, they have, the last one had over 1,200 psychiatrists. They're fantastic range of topics. They cover everything. We have high profile keynote speakers, and it's just a great kind of party. Now, sadly, we had planned this year's meeting for Phoenix, which it would be a fantastic place to be, but COVID has changed everything. And so we are now going to have a virtual meeting. Now, the good news for you people is that means you can join from here. And it also is going to be cheap for you, because Academy faculty members count as members of ACLP. And because it's a virtual meeting, it's going to be really quite cheap. If you want to see the prices, there's a dedicated conference website, clp2020.org. Have a look at that and you'll see it's just going to be on 2 days. We're going to have lots of live content. There's going to be, if you pay for to go to the meeting, there's going to be huge amounts of material in a library of recorded content that you'll have access to for about 3 months. So I would very strongly recommend it. The keynotes include Tony Fauci, who you may know is the leading physician for policy about COVID in the USA, works with the president. Kurt Kroenke, the hero of symptom research, developer of the PHQ-9, GAD-7. Sanjeev Socklingham, who has done wonderful work in integrated obesity management in Toronto. A surgeon who became very ill and has had an intensive care experience and subsequently developed PTSD, from which he's recovered. We'll be talking about his experience, Tom Gillespie. We've got John Schuster, who is talking about the role of humor in medicine. He's a professional, semi-professional comedian as well as CL psychiatrist. A guy called Bert James, who, if you heard of Intermountain Health, he was the surgeon that created the innovative healthcare in Intermountain Health. So it goes on. It's going to be absolutely fantastic. So I do hope some people come, because we get a rather disappointing number of British people and Europeans actually at the American meeting, from my perspective, say, here's your chance to go without having to fly. I'm not sure there's another slide, is there, Alex? Is that the last one? That's it. I'm done. Thank you.
You're done. So thanks very much. And it's now just coming up to 7:45. So we've got a good 15 minutes for questions. So the reason the slides get a bit fractured is I'm running this all from a single laptop. I really need 2 screens, so I've got like chat boxes and stuff up there, and sometimes you see a little bit. So I won't apologise if you can see stuff now, because we just got a Q&A holding slide. I will just hand over to Shami, who's been monitoring the questions and the chat, and if you could put some questions to our speakers.
Thanks, Alex. So we started these webinars to help quell the anxiety around COVID, and a lot of it kick-started quite a few crisis hubs and ED diversion units. And now there's been a lot of discussion in the chat and questions about how these mental health emergency centres are going. And I wonder, both Michael and Trudy, what your thoughts are on the continued use of these mental health emergency centres or diversion units. If I start with Michael.
Well, as some of my colleagues know, I work entirely in the acute hospital. So I should know more about what happens in the mental health services, but I'm not a good person to talk about it. You know, it's this whole, speak to this whole topic of how integrated we should be, and should we be splitting off this mental bit of care. And I'm afraid I'm a bit like a biblical fundamentalist, because I don't think we should have separate mental health trusts. I just think we should take care of people as they come. And so anything that separates and diverts, to my mind, is not a good thing. But I understand on a practical basis, the way things are at the moment, I guess that's what we've got to do. But I haven't experienced about how they've worked.
Thank you. And Trudy, I was wondering what your thoughts are.
Am I back on? Yeah, sorry, I took myself off. Yes. Golly, it's really complicated, isn't it? Because, you know, having, you know, being a, you know, general adult and liaison as well, I mean, as well as a perinatal psychiatrist in time, I know that's been my main clinical area, but actually also having sort of tried to look after some of these services at a trust-wide and an SLP level, it's really difficult. We you know, we've had to set things up very quickly because of COVID, but I know the sort of alternative to EDU offer was around pre-COVID, and there are examples. I mean, Alex, we work in a patch of London of alternatives, and it's, I guess it's fundamentally, it's that sort of integration of psychological and medical, and that integrated model. And you know, in an ideal setting, I think one would want our ED departments, for example, and if we were going to have some sort of clinical decision unit, the ideal would be it sits right next to, you know, an emergency department, because we can't lose the integration of needing to look at what's happening physically with the psychological part. I mean, we can't, and the idea that it can be completely separated goes against the grain of, you know, the parity of what we've been working for in psychiatry for such a long time. So those are the challenges. I don't like hearing from acute trust colleagues, please can you find somewhere else for people with mental health problems to go to. I don't like hearing that, and I don't think anyone does. But the other side of it is that there are some people perhaps presenting in crisis who would be better served in a much quieter, more pleasant environment. And actually, both across sort of adult, child focus groups, and some of the I statements we had from, you know, young people and from the adults and older adults, is that, you know, if possible, there was a preference for a separate area that wasn't so chaotic. So we need to listen to that as well. So I think we've got a long way to go. I think, sorry, that's a, you know, long ramble, isn't it? But I think we've still got a long way to go. I think
Absolutely.
that would, yeah. So we've had to step, you know, having stepped up services, we've had to step things down again. Young people absolutely didn't want to travel, as neither did adults across several boroughs. You know, do we have a completely separate area for young people and a completely separate area for adults? It's a lot more thinking to do.
Absolutely, and I think while it's a very difficult area to sort of formally evaluate and research, and things have been a bit of a muddle and a jumble, with things being set up very rapidly, but very flexibly and very, very willingly. There's probably a need for a sort of rapid summary of different models to see what is working, you know, what the pros and cons of the various approaches are, and you know, perhaps move towards consensus or local options, because I think it's going to depend very much on the local context and other service configurations as well. I've just heard this week, in fact, that some emergency departments have expanded like very large mental health facilities within the emergency department that are still on the clock, and have purpose-built facilities that are not a separate unit but are actually, you know, have like 4 or 5 mental health rooms in the emergency department. And I'm quite interested in looking at whether we can adopt that locally. In fact, moving on to another question.
Thanks, Alex. Moving on sort of from COVID to immunology, there's a question about whether psychiatrists should upskill on immunology as quite a huge area of growth in neuroscience research. And if I start with Michael, the question sort of further asks if any North American consultation-liaison psychiatrists are also getting educated on immunology.
So I think one of the things this speaks to, one of the things I like about American sales psychiatry, is they are psychiatrists, they're trained psychiatrists, but they regard themselves as physicians who specialize in psychiatry. It took me a bit, you know, we tend to refer here the psychiatrists and the physicians, but in the States, they say that we're physicians. Now, I wouldn't say everybody is into this, but there is a significant group. I can't guarantee the stuff on this in the annual meeting, but I expect there will be. Important thing from my point of view that I found from the US is we need to hang on to our physicianly training and physicianly roots. And that means keeping up with this kind of stuff.
Thank you. And Trudy, I was wondering if you had any thoughts on the role of immunology or other areas of research.
Well, I fundamentally agree with Michael, and I think that's what we should be. You know, I think we need to remind ourselves, I mean, that we are, you know, we've trained as physicians, you know, we've trained as doctors, haven't we? And I think that's really important in a world, particularly I think in the UK, it feels like it's very much a UK area where, you know, the identity of what a psychiatrist does is being, you know, is being examined under a microscope in lots of different ways, including sort of the role of, you know, psychiatrists as psychological therapists, etc., as well as physicians. So, you know, we are fundamentally doctors, and I think it's important to maintain that. So within the, I guess, the immunology story, it's critical that we understand immunology, because it's, you know, that it's a growing, evolving story. I mean, you know, we do look at lots of immune markers, actually. For example, you know, taking blood for things like thyroid autoantibodies and potassium-gated channels, and you know, that's what I routinely do when someone presents with first onset postpartum psychosis, is to check for that sort of stuff. And I think we need to understand it and be on top of it. I think we need to do that as psychiatrists, not necessarily, not just liaison psychiatrists, all psychiatrists, if we're dealing with conditions like first onset psychosis. So definitely, you know, but I think we can do that in our psychiatry training, because part of what we do is immerse ourselves in that knowledge and information. We may choose not to pursue it, but actually we should understand it. There was sorry, you're probably going to go on to the other question, but
no, it's all right.
Yeah, so it's a you know, inflammation, immunology, its correlations with psychosis and depression, anxiety. Those are, you know, key areas we need to understand and know.
Absolutely, and we should remember that the college has the Gatsby Welcome Neuroscience program, which is ongoing, and we were going to hear something about that at the faculty conference this year, which never quite happened, but I hope that can come up in the future. We've just got probably 5 minutes, so maybe time for 2 more questions, and I wonder if I can just sort of pull up. There's someone's asked a question about primary care-led models like IAPT, improving access to psychological therapies, working closer with liaison psychiatry, and that this brings up the question of how do we collaborate with psychologists and therapists, and I guess for the ACLP, how does this work in the USA? And I guess for the Royal College as well, how can we better collaborate with organisations like the British Psychological Society to make sure that consultation liaison psychiatry and health psychology and clinical psychology are really integrated and working together rather than sort of separately but in parallel?
To speak to that, well, the good, the bad, and the ugly. So just to come back to the UK, I mean, I'm very pleased to say that in Oxford University hospitals, we have a directorate, part of the trust structure, which is called psychological medicine, and that comprises psychiatrists and psychologists working together. There's no separate thing. I think we probably need to develop actually other roles, physician assistant type roles, because there aren't going to be enough psychiatrists as the need in these systems is recognized. One of the downsides of America, because partly to do with funding and competing for funding, is there is a bit of tribalism between psychiatry and psychology. So they have separate organizations. We do have some psychologists come to the academy, but that's not an easy relationship because they are competitive. And with psychologists starting to prescribe, and then potentially coming in as a cheaper way to supply the services, that's an awkward situation for psychiatrists. So yeah, of course we should be doing it, but good old-fashioned money and tribalism gets in the way.
Alas. And Trudy, I mean, the college and the BPS put out a statement of intent about a year ago. How are we getting on with the BPS? Any?
I'm not aware of an update around that actually, yeah. To share today. But I think fundamentally it's really important that different disciplines are working together for the benefit of the people that we're looking after. We have a whole range of disciplines and professionals and expertise that we bring to look at mental illness, whether it's a biological stance or psychological, etc. So that's the important bit. Everyone has a place to do something. Yeah, so hopefully we'll move that agenda to a much better place as we go forwards.
And for people
that's a hope.
So I just say, for people working in general hospitals, you'll often find that there are psychologists well embedded in the hospital already, often employed by the acute trust. And I know in most services, psychiatrists are employed by the mental health trust. You already have a fracture there. But some of the psychologists have been embedded and working as part of the acute trust for a very long time, sometimes decades. So actually, in a sense, they have been ahead of us in many ways. And I think it really behoves us to join forces.
Absolutely, and I think it's certainly been pointed out to me before that it's not as if there's not enough need to be met. So there is plenty of room, I think, for all of us, because there's certainly not enough psychologists, not enough psychiatrists to go round. So how do we collaborate rather than compete? But it's just come up to 8 o'clock, so I will just finish things off there. So I'd like to thank everybody who has joined us tonight. Of course, all the delegates who've really helped, with asking questions and, chatting and commenting. And of course, thanks very much to our two really good speakers for giving your time and your experience and expertise tonight. So we can't end with a round of applause, but we'll have a virtual round of applause. And I'll just say, on behalf of the audience, thank you very much for your time and your talks and discussion.
Thank you, Alex.
This evening.
Thank you, everyone.
So thanks very much, everyone. Okay.
Thank you, Alex, and thanks everyone. It's been a pleasure.